And thank you to Medicine 2 and for inviting me to talk, and of course to my unit. I'm just looking at challenges in therapy, mainly. Like Audrey just mentioned, it's always difficult to figure out how we can try drugs or try new therapy procedures in pregnant women. Just a few thoughts from my side. So my outline is looking at redefining drug therapy in pregnancy. I call it targeted therapy in heart failure. I know we've heard a lot of targeted therapy for cancer, but I'm looking at targeted therapy in pregnancy and a relook at drug categorization in pregnancy with respect to dyslipidemia. And for the cutting edge, it's placenta on a chip, which I'll come to later, because this is how you can actually study drug therapy in pregnancy without actually doing it in a pregnant woman, which is dangerous. So as I said, targeted therapy, when you define it, it's actually a drug or a therapeutic strategy with a focused mechanism, specifically acting on a well-defined target or biological pathway. And when inactivity causes regression and destruction of cancer, it's usually used for cancer. In pregnancy, we can actually look at targeted therapy to actually overcome an excess of normal metabolic inflammatory or hormonal effects, which are causing a problem. Just to go backwards, pregnancy obviously has a complex metabolic and hormonal milieu. And unfortunately, it changes with each trimester. It doesn't even stay static. And the maternal metabolism is usually altered to redirect nutrients to the placenta and fetus. And as seen over here, you can actually, obviously, this is how the hormones go. This is just the hormonal profile. And if you can see the variation, it's quite difficult to keep up even with the hormones. And for each patient with additional risk factors, it may become different. So I'm looking at targeted therapy by defining medications for peripartum cardiomyopathy, which I'll call PPCM from now on. We'll just look briefly at incidence and definition of PPCM, current management strategies, and the concept of targeted therapy in PPCM. So here we have statistics of the incidence of peripartum cardiomyopathy. India is about 73. This is incidence in 1 lakh births. But of course, we have a high maternal mortality rate also. In a study that Aditya did when he was with us, we looked at women with peripartum cardiomyopathy within our institution who had enrolled, and we had 1 case per every 1,541 births. And we looked at 54 women during that study, and the mean gestational age was around 35 weeks. So when you define peripartum cardiomyopathy, it's a form of heart failure with a new onset left ventricular ejection fraction less than 45%, occurring towards the end of pregnancy or the months after delivery, in the absence of other identifiable causes of heart failure or recognizable pre-existing structural heart disease. So this is an algorithm of how we look at it. But here, let's like to pause and say most of the time, the women are just orthopnic, mildly. They may be just breathless or tachycardic. They are not going to be overtly in cardiac failure like we see in our non-pregnant population. So one is the subtleness of the signs and symptoms. Second, what we've found useful actually, as we said, there's the next step is echocardiography. Next step is echocardiography. But for us, BNP plays an important role because the signs and symptoms are very subtle. And doing a BNP usually will pick up, like it picks up heart failure in the non-pregnant individual. And then afterwards, based on the definition, depending on the ejection fraction, if it's less than 45% or greater than 45, we end up talking about PPCM if no other pathology has been found. So the pregnant host has very subtle symptoms and signs, and BNP is more useful than troponins. And also to add on that, how do you decide who gets peripartum cardiomyopathy? Unfortunately, quite varied. But even though there's a list of reasons given above, what we have seen is mainly with the preeclampsia, older age group, twin pregnancies. Those are the population that we found people having peripartum cardiomyopathy. There's also the point below here when you look at risk for subsequent pregnancies. In the cultural context, however much we explain or counsel our patients, inevitably, there is a cultural pressure to have more children or have children at all. So the important ones that I'd like to point out is lower the ejection fraction at the time of the index pregnancy. There's a high risk of developing PPCM in the next pregnancy. And unfortunately, after that, they may actually continue to be in cardiac failure. And when I say this, I also worry because you're looking at average age of 25 years or 26 years. You will have people with cardiac failure with young families and work at home. So the traditional treatment of PPCM, as for heart failure and the non-pregnant, we use beta blockers, ACE inhibitors, ARB. Of course, I'm talking about ACE and ARB because they would have usually delivered by that time. And diuretics, we don't use the mineralocorticoid receptor antagonist so much, but because of fetal issues, but of lactation. But beta blockers, ACE inhibitors, diuretics are usual management. So this comes also with a problem. When you look at outcomes in PPCM, 6-month outcomes, various studies they've done, there are mortality rates going from 2 to 12. 24-month outcome in Turkey at 24, and ours was about a 9%. So even with the best case tertiary care picked up on time, medicines given, people are going to die. And women are going to die with small babies. So that's quite heartbreaking because this is a disease that you don't know you're going to get till you actually, it pops you just after you've delivered when you're supposed to be happy or breathless. So that is the problem with outcomes in PPCM. And when you look at studies in PPCM and subsequent pregnancies, these are various studies done where they've looked at cohorts. So you can see that this particular study had 45 people and 30 recovered, 15 had recovered, so almost 50%. They go on to have a second baby, and out of that, 7 have not recovered. So it's kind of a progressive thing. And if you ask me what are the statistics, if you take a population of people with PPCM, about 30 to 40% will recover. Around 30 of them percent will stay at the same EF, which is low, and some of them become worse. So not exactly an exciting statistics. And if you look at each of the studies after that, almost 50% are sitting there unrecovered, other than for one particular study. This was a cohort where there was a mix of patients of African origin and white European. So at the end of this, when you look at it, again, just to summarize, persistent LV dysfunction, this is a recommend, and increased morbidity with subsequent pregnancies, and premature delivery and abortion more common. If they have a complete recovery after the first PPCM episode, they have a better situation with the subsequent pregnancy, but 20% can have a relapse. But so the most important thing would be the recovery from the previous episode. But recovered ejection fraction from the first pregnancy is not necessarily protective for the second pregnancy. And after that, if it reduces, they can stay like that all their lives. So how do we improve long-term outcomes for a pathology within a physiology? This is my classic line, which now my PGs quote back to me, where I say pregnancy is a physiological process. It's never meant to have pathology. So I'm looking at something from a bedside to bench and then coming back. PPCM is a complex disease because nobody does know what is the single reason why somebody would develop PPCM over another. These are a lot of the long list of things that people have talked about contributing maybe to PPCM, but nothing has been proven. But recently, the interest has come on targeting a certain process. So they looked at biomarkers for PPCM and found increased levels of cathepsin D. That's an enzyme that generates the 16 kilodalton prolactin. They found microRNA, which is a direct target or comes from the 16 kilodalton prolactin. Of course, BMP will be high, and something called asymmetric dimethylarginine. I'm just going to focus on the prolactin part. So if you look at it, this was actually a study where they measured levels. BNP, of course, was higher as compared to control patients. This ADMA was high, and this cathepsin D also was high, which is coming from prolactin. Now, when you look at it, you may say, hey, won't prolactin go up anyway? I mean, this is a lactating mother, but we're looking at controls who were pregnant patients. They were healthy pregnant patients versus patients with PPCM. So what was concluded was there was high levels of the hormone prolactin, and probably with oxidative stress, there was cleavage of the prolactin into smaller anti-angiogenic fragments, which is the 16 kilodalton prolactin, that causes endothelial damage. There was also release of these microparticles or the microRNAs, which is induced by 16 kilodalton prolactin. It's almost like a spiral. You get one, then you get the other, and they all add on to inflammation. So then they wondered, what if we inhibit this prolactin release? Would that help? Because obviously you're in a milieu where the prolactin is high and exceptionally high in these women. So from 2007 to 2008, there was a proof of concept. They created a mouse model to again prove that these levels were high. And then they did a small study, just 20 women. They treated some with severe PPCM only with standard heart therapy medication, some with bromocriptine. And at 6 months, the recovery was obviously from 27% to 58%. This is the ejection fraction with the bromocriptine group, but the normal group, the standard therapy group, went from 27 to 36. Then in 2013, they did larger studies because they said, hey, let's see whether they need bromocriptine alone or they need standard heart therapy also. This one was not very significant, but what they found is that they need the normal therapy along with bromocriptine. So just that it was strengthening the role of anti-failure medications. Very honestly, here we are just giving anti-failure medications and praying that they do well. But there was an option of giving standard therapy and adding on bromocriptine. Now, Hilfiger and Cleaner, this group, actually they looked at severe LV dysfunction in PPCM, less than 35%, and went on to give short duration and long duration bromocriptine. They either gave it for a week or they gave it for 8 weeks. You can see the dosages there. And look at the LV function. It went in the 1 week group from around 28% to 49%, and from 27 to 51 in the 8-week group. And after this, they just said that the risk in the 8-week group to fail full recovery after 6 months tended to be lower. But otherwise, the short and long were almost equal. Now, why would we say short and long? Why not just give them long? Remember, there's a function the mother has to do. The mother is supposed to feed the baby, and you're going and actually suppressing off the prolactin. So there are other issues with just doing it blindly. But of course, you don't want a sick, breathless mother who's going to die. That's the trade-off. So what are the side effects of bromocriptine? Generally well tolerated, but when you give bromocriptine, there's an increased risk of thrombosis in an already prothrombotic milieu. So DVT prophylaxis is recommended for that week. Lactation suppression may be detrimental for babies in low-income countries. So that's also come up. Obviously, all of these studies are done in very small groups of people, but you're looking at mortality in a mother and you don't want an orphan at the end of it. So they've made this, it's called the board combination. Someone was being very amusing they were being funny when they said, welcome on board, which means bromocriptine, oral heart failure medications, anticoagulations, relaxants if needed, and diuretics. So it's called the board therapy for bromocriptine in peripartum cardiomyopathy along with standard medications. So this is one recommendation from a group saying mild PPCM, ejection fraction is 35 to 45. You can consider 1 week of bromocriptine. Moderate ejection fraction of 20 to 35. You can consider the 8 weeks if LVF is less than 25, but remember the anticoagulation. And severe PPCM, again consider 8 weeks. And of course, you may need other levels of medical intervention. But this is all to bring them back quicker to normal EF and hopefully have a lasting effect. So can I get pregnant again is what we are going to be asked, believe me. And so we don't know. We just know that you can give bromocriptine in each pregnancy, but does giving it in the first pregnancy help the second one? Those studies have not yet been done. So that was the first part of my targeted therapy in pregnancy. But do remember again, you do want to feed the children, you will have to decide on the benefit versus risk. But having said that, if you look at bromocriptine for treating heart failure non-pregnant, there's a 1983 trial where they use bromocriptine as a vasodilator, and it's got an anti-sympathomimetic action for heart failure in general. So I think there's some studies to learn from the pregnant studies to the non-pregnant. This is just for general advice. And it can be used for its own effects. Now I'm going next to drug categorization in pregnancy and some considerations. I think when we look at any drug, we say who or what was this population, what population was the drug studied in, and does my patient fall into this population? And what comorbidities does my patient have that might impact my choice? Both these questions in pregnancy have different answers. The pregnant population is excluded usually, and pregnancy is not a comorbidity as we all keep saying. So therapeutic decisions peculiar to pregnancies, does the disease, we're talking about chronic medical conditions in pregnancy, does it allow for conception? If yes, can the disease be controlled on medications before conception? And if that is a yes, can the change of medicines during pregnancy ensure control of the disease? And of course, what are the effects on the fetus if the preconception drugs are not changed or stopped? So we need a washout period. Classically, washout period is used in trials, but here you need a washout period before people become pregnant while balancing a chronic disease. So methotrexate, if somebody is on, then they will have to stop it for about 3 to 6 months prior. So the peculiar thing is, if you realize that a pregnancy test, a woman knows she's pregnant approximately 3 weeks after the last menstrual period, and most home tests will just pick up a HCG of 25. So if you look at it, when is the test going to be positive? Here. By then, you have taken 4 weeks of some drug. If you don't know better, some drugs, some people are counseled well, so they stop earlier. So even at best case scenario, a person has taken it for 4 weeks before they stop it. So we see this often in our OMC clinic, and then we've seen people on mycophenolate. We've seen people who just didn't realize they became pregnant by accident. And during those 4 weeks, this is what is going to happen. All of these dark is major malformations. When it starts getting checkered, it is major functional and minor structural. They're all major structural. So there's a high chance that a woman may not realize she's on a drug and have a pregnancy test at a time when she's still on the drug, because that's the way HCG goes, and we don't have much of a choice in that matter. So FDA had categorized based on this. Because of this, we have drugs. We all know about these categories, and going from A, B, C, D to X, with X being absolutely contraindicated and A having no risk. There's an Australian categorization also, which converts B into B1, B2, B3 also, depending on animal studies. So this is what we know. Now, why am I bringing this up? Because the FDA itself has realized that this is not the best way to categorize drugs. And now they categorize it as a PLLR rule. And they say all drugs should actually have this information. Now, if you ask me, the US is also very far away from implementing this, but this is the ideal way that each drug has to be thought of, because some drugs actually don't cause problems. And they're taken off from a pregnant woman because we don't know better. And we can't use them in studies. So that's the worry. So I'm just putting it, I'm conscious of the time. So the case study is of dyslipidemia management and drugs in pregnancy. I'll just briefly talk about this. And dyslipidemia drugs, okay, these are the things. So when you look at the global burden of disease, I brought in categorization in this because I'm going to talk about statins, which is formally categorized as X category. That is, you can't give it at all. But when you look at global burden of disease for women, there's an increase in CVD-related fatalities among women, surpassing that of men. And now CVD is the leading cause of death among Indian women. Can you see those little orange is greater than 15% change from death rate from 2010 to 2019. We have a lot of orange sitting there. In fact, maybe the others are underreported, but we are the only orange country, which is not helping very much. And we've also found it to be more in women. And highest number of CVD deaths other than China is India. You may say it's our population, but still it's high between 2010 and 2019. So now everybody is re-looking at statins for everyone, especially women. So the Lancet Women and Cardiovascular Disease Commission said we have to reduce the global burden by 2030. And when they looked at women again, they said some things which even Audrey has mentioned. You can't see the slide. I'm so sorry. It's not clear. There are specific specific risk factors which make it worse for a lady. And those are the factors which nobody is looking at. It could be a preeclampsia. It could be a gestational diabetes. It could even be dyslipidemia. So I think all our talks link to each other. Esther talked about how to bring down all of our, metabolic issues. And I think women are not taking it seriously enough. And pregnancy is one process, as Audrey talked, where we actually have an increased risk for metabolic risk factors. So lipid metabolism in pregnancy, you can see how the HDL stays here. But the LDL goes up, the total cholesterol goes up, and the triglyceride also goes up between conception and delivery. This is needed for the baby. The baby needs the lipids for neurodevelopment. But if you look at pre-existing dyslipidemias in pregnancy, the outcomes are a bit bad for the maternal outcomes, eclampsia, hypertension, metabolics, and some things for the baby also. So having all this base, now even the American Heart Association, various people, including the FDA, said, hey, there are people and there are more women now with cardiovascular risk. should we look at it again? Look at the role of statins again. There's always a role for diet, but unfortunately, when you're pregnant, you're not exactly dieting. So statins were a category X that was actually based on lovastatin, which we don't get, which was used. It's a lipophilic statin, which a few studies were done and said they were fetal malformations. Now, other cohort studies after that, these have not been intentional cohort studies. These are follow-up cohort studies of people who accidentally took stat, have not found any teratogenic risk. So having said that, now there's a recommendation from FDA in 2021 to say statins is gone off from X, but use it carefully, use it wisely, use it for the people who may need it, especially women with already risk factors and those who have familial hyperlipidemias. So this is a new thought that has come. I will take 2 minutes more if everybody allows me. So the further therapeutic research for pregnancy then involves creating models of the placenta. You have to create a model of the placenta so that you can study drug therapy. Auden just mentioned when he finished that it's difficult to study half of the therapy because the placenta is such a complex organ. So they've come up with something called a placenta on a chip. It's literally a small little reproduction of a placenta. It's not very complicated. By the way, it's developed in India also. The DST is actively involved in creating the placenta on a chip. But you had to create a model that looks exactly like the placenta. One side maternal flow, one side fetal flow, and in between there has to be a barrier which is porous. So this is how a placenta on a chip looks. It consists of a semi-permeable membrane, 2 tiny chambers, one filled with maternal cells from a delivered placenta and the other side with fetal cells from a umbilical cord. That image shows it correctly. This is what, and this is what they've reproduced here. So testing the placenta on a chip, these are all engineers who have done this, saying that, hey, there has to be something. So this, I like this study particularly because they looked at caffeine. I remember all of us wondering how we'll stay off coffee when we were pregnant. It was difficult, but we had to. So they modeled it by giving a caffeine concentration on the maternal side and then monitored it. Unfortunately for all of us, after 6.5 hours, when there was a steady state, there was caffeine on the fetal side also. So there are various such models which can be developed so that we can study drug therapy, since we have been struggling with which drugs can be given and not given. So these are the lines. On one side, on top will be the maternal, they call it the BVOS, which is human trophoblast cell line. And this is the HUVEX, or the human primary placental villus endothelial cells on the other side. So this is what has been developed from the DST. They have various chips depending on which trimester of pregnancy there is. So take-home thoughts, targeted therapy in pregnancy, which we looked at bromocriptine. We know it for the primary index case, categorization and recategorization of drugs to help reduce complications, and placenta on a chip to study therapeutics in pregnancy with no harm to the fetus. Thank you.
Thank you, ma'am. I would like to invite our next speaker, Dr. Sudha Jasmine. Ma'am is the professor and head